Hi, good afternoon, everyone. This is Katie Kopp. I'm glad to be here with you all this afternoon. We have a real privilege to hear from Susan Ford this afternoon. She is from the Ohio Perinatal Quality Collaborative, and they have done really great work on NAS that we are really fortunate to learn from. And I have to brag on Susan a little bit. She is on vacation right now and has still really graciously agreed to be presenting for us. So we have a lot to learn. I did just a few housekeeping items before I turn this over to Susan. I have placed everyone on mute just to cut down on the background noise, but you're welcome to communicate through the chat box. I'll be monitoring that. And then at the end, we can open the lines up for questions as well. So with that, I will go ahead and turn this over to Susan.
Thank you, Katie. Can you hear me?
Yes, we can hear you.
Very good. Well, thank you very much. I'd like to start out, good afternoon, everyone. I'd like to start out by thanking Katie and the Georgia Perinatal Quality Collaborative for the opportunity today to present our work from Ohio. I'm really excited to share it, and I think that I think that one of the best features of a quality collaborative is just that sharing. I think that I learned so much from other quality collaboratives, and hopeful that you will take away some nuggets today that I can share with you. I'm Susan Ford, like Katie said. I am the State Quality Improvement Consultant working with OPQC. I led the NAS project. We went from 2014 to 2018 with our active phase of the project, and the last 18 months were in a sustained phase, and I would say now that that active project has closed out. So I'm really excited to share our learnings with you. A little bit about me. My background is in maternal child nursing. I've worked both as a NICU nurse and a labor and delivery nurse for many years in the past. And about 10 years ago, I started working with the Director of Quality at Rainbow Babies and Children's Hospital, where I'm from, which led me to this QI position with OPQC. And I think that I always felt that I did a really good job one-on-one with patients and their parents, and I really welcome the opportunity to work with a quality collaborative where we're able to touch so many lives and impact so many more. And kudos to you as well in Georgia for moving forward with this. All right, with that, let's get started. Today's objectives, just to identify potentially better practices with both farm and non-farm treatment for babies with NAS. I want to talk a little bit about the Ohio Perinatal Quality Collaborative methodology that we use and what we used specifically with our NAS project. And lastly, talk about the impact of standardizing care on decreasing length of opioid treatment and length of stay for babies with NAS. I'll start out with some national data here. So we have, if you're looking at this, this is age-adjusted drug overdose death rates by state in 2016. And you can see that the U.S. rate is 19.8 per 100,000 standard population, and that navy blue, that dark blue, is statistically higher than that U.S. rate. Georgia, kudos, has a green, statistically lower than U.S. rate. Sadly, we do in Ohio have a statistically higher than U.S. If we look at the total opioid overdose deaths, and again, this is national data, we're looking at Ohio again with an increase of 325% over a 5-year period from 2009 to 2014, and just causing numerous deaths across the state of Ohio. The equivalent of 6 Ohioans dying every day, or 1 Ohioan dying every 4 hours from an opioid overdose. And I share this with you just to tell you about the impact in Ohio that is rising from this with NAS. Next slide. If we're looking at national data also with maternal opiate use and NAS from 2004 to 2014, it has increased from 1.5 to 8.0 per 1,000 births. That's an increase of 433%. That's impressive. Also impacted is Medicaid, who is the primary payer of these hospitalizations for NAS births, and they went from 2.8 to 14.4 per 1,000 hospital births. Really quite a burden of death there. Next slide, please. So if we're looking specifically at Ohio with drug dependence at time of delivery, we have 11-year spread here, and you can see that it's just total increase there from 2006 to 2017 if we're looking at the total number of mothers diagnosed with dependence. The orange, that's the green line. The orange line is indicative of marijuana use, and then right underneath that is opioid use that we're seeing. And again, this is data from the Ohio Hospital Association based on claims data. We can go to the next slide. Not surprising, with the increase in maternal drug usage at delivery, there's also an increase in incidence of NAS. And you can see that we had from 2006 to 2017 in the state of Ohio, we had a discharge rate from 20 per 10,000 at 2006 to 2017, that number jumped to 140 per 10,000 hospital births. So that's approximately 6.3 times the rate over an 11-year period. The cost, again, I mentioned Medicaid. In 2015 in Ohio, Medicaid was the payer for approximately 89, just about 90% of the NAS inpatient population. And then cost of that was over $130 million and over 30,000 days for these babies in Ohio's hospitals. So let's go to why standardize. You could go back to that other one, Katie. Just talking about the focus of my talk today will be standardizing care in Ohio for the NAS infant. And then the next slide, why standardize? And really, standardization is really an important QI tool. I think when we think of algorithms in the ER, with CPR, with the neonatal resuscitation, really you want a standardized approach. It will decrease your variability and increase your reliability. And our next slide shows also, this is American College of Obstetrics and Gynecologists, committee opinion also, just to utilize clinical guidelines and standardization to improve outcomes. I think the evidence is there that this is definitely accepted amongst the medical community and really a way that that is utilized for patient safety, for patient outcomes, and like I said, really increasing reliability. Next slide. I'm jumping ahead prior to explaining this first part of our project to the part here that is the write-up of the project, the manuscript here. And if you go to the next slide, there you go, you'll see that it didn't really matter what protocol was used with the first arm of this project, as long as the protocol was utilized and adhered to, regardless of the protocol itself. That in itself reduced the duration of opioid exposure and length of hospital stay. So this was something that, again, it was the outcome of the first arm of the project, and I wanted to put that out there since we're talking about standardization before I give you the highlights of the project itself. Let's go to the next slide. And this is not the Ohio Perinatal Quality Collaborative project, but this is the Ohio Children's Hospital Association, NAS consortium. This predates our project. It went from September 2012 to September 2014, and there were 6 children's hospitals on a tour with then Governor John Kasich at Nationwide Children's in Columbus. And he was walking through the NICU and asked the physician leads throughout the state at the children's hospitals what they did to work together to improve outcomes for children in Ohio. And one of the hospitals said, we're working on obesity. And others said, we're working on asthma management. Several were talking about pressure ulcers in the PICU or line sepsis. And he said, but that's great. What are you working on together, though? That's what I'm interested in. And there wasn't really much that they were working together. They were kind of siloed. So he offered them a good chunk of change. They were able to get $2 million over the course of the 2 years to go ahead and work on something together. And the children's hospitals at that time in 2012 selected neonatal abstinence syndrome to work on. Two of the sites, Nationwide Children's in the middle of the state there and Cincinnati Children's, both had affiliates that they were in other hospitals. So I don't know if in Georgia there's a setup like this, but for instance, Nationwide Children's will be in, they will own and operate the NICU in other larger hospitals. So those affiliates, both in Nationwide Children's and Cincinnati Children's with that same model, all worked on this for a period of 2 years with the goals of understanding the epidemiology of the moms and the babies, determining what was possibly a better practice. Was there something out there that they could use? All these sites were using different approaches to treat NAS, and then to identify variation in areas for future research. So if we go to the next slide, this is the demographic of the moms. Most were young, single, white. 80% of them were on public insurance. 85% had pregnancy complications. 26% Hep C positive, and 82% used tobacco products. And I have to say, I was a little surprised with the 82%. I've always heard that to be closer up to the 90 percentile. So there were 553 babies born from these moms. Let's go to the next slide. This is the first year here. And the infant treatment characteristics, symptoms started at a mean about 46 hours. The opioid treatment days were about 20 days, and then the day of life at discharge mean was 22.4 days. Number of drugs used, the mean was 1.5. Some were using phenobarbital and clonidine also, in addition to either morphine or methadone. So you'll see that morphine only or methadone only, a little bit of variation there, not quite getting up to 100%. And that is because some sites were using methadone and morphine. So I think that is a really important point for standardization right there, just with the potential for error. All right, let's go to the next slide. These next two slides really, I feel, are probably the most important of my talk today. This is the impact of the weaning protocol for this first project with the Ohio Children's Hospital Association. So about a year in, it became apparent that there was a potentially better weaning protocol. Everybody was testing protocol. They selected a protocol. They said you pick morphine or methadone, and then they kind of landed on what they thought was a good approach, and all 6 hospitals with their affiliates decided to adopt that. They went ahead and had 462 babies already in their database at that point, and then after adopting, they had another 392. If you look at Site D, you will see that their length of treatment is markedly longer than their length of stay. And there's a reason for that. It is because that site elected to, those babies were on methadone, and those babies were sent home on methadone to wean at home with the assistance of a local pediatrician, and they continued to do that through this stage of the protocol. So they were not included in the number of babies, and they weren't included in the data because it skewed it, and they weren't adhering to the protocol that they were testing. So what I think is most impactful, if you'll look on the left-hand side, you'll see that y-axis, the top line, the top of the graph there, has a number of 50 days. The change was so dramatic when sites adhered to the weaning protocol that they had to alter the graph, and it actually, the y-axis upper limit was 35 after adopting the weaning protocol, which, again, like I said, pretty powerful. If we look at the next slide, this is from one of those specific sites, and the neonatal nurse practitioner lead put this together. On the y-axis, we're looking at the number of days, and at the x-axis on the bottom, we're looking at the number of babies treated throughout the year. So you'll see that the green line, there's length of treatment, and there's like a data point for each baby. If you're looking at the blue line, this is the average length of stay, and then the red is the average length of treatment for all. So you'll see by standardizing, they started out by standardizing inter-rater reliability of the Finnegan scoring to identify the babies with NAS. They started that in October 2012 and had a pretty quick drop. and were able to decrease their average length of treatment to 38 days, where it was pretty close to 60, maybe 57, 58 up there. A new protocol came out a bit later, and you can see when they implemented and initiated and implemented that standardized treatment protocol, again, they decreased their average length of treatment down to 17 days. Really impressive. Like I said, I think that these two data slides with the y-axis and then again with a length of treatment and a length of stay decreasing so dramatically, I think that this truly speaks to the need for standardization of care from a team that did not have that prior to participating in that project. So let's go to the next slide. When Medicaid, who was involved as well, was aware of the work that Ohio Children's Hospital Association was achieving with this project, they were very interested in spreading this throughout the state. And so Ohio Perinatal Quality Collaborative went ahead and was funded by Medicaid to go ahead and spread this. So 54 total sites participated, and I want to point out that 26 of those were already participating in the initial OCHA site. So we had all the level 3 NICUs in the state participating, 26 out of the 28 level 2 special care nurseries. There were 2 sites that were unable to, they just didn't have the bandwidth and felt that their numbers were really low enough that, that they were not able to do that. And then 2 normal newborn nurseries, and that was a bit unusual. They were included in this project because they had a pretty large number of NAS babies that they did treat pharmacologically. So they also participated in the project. And like I said, it was funded by the Ohio Department of Medicaid and started in January of 2014. And you can see we have a pretty good spread throughout the state there. Next slide, please. This is a real busy slide, and I won't go into too much detail. This is our key driver diagram, and our SMART aim was to decrease the length of stay by 20%. It was a lofty goal. We did not achieve that, but we did probably would have taken into effect, we didn't really think about the teams that were coming in had already been working for 2 years on this. And you saw on that one slide of the site that once they did standardize the decreases from, I think we had about 47, 48 for length of stay that went down to 17. So you can, those numbers didn't go into this, but I think that perhaps in retrospect, we might have said maybe 15% might have been a more appropriate goal. At any rate, our key drivers were to improve recognition, really in a non-judgmental, compassionate manner with the moms, and then increase the reliability of NAS scoring with the Finnegan system, optimize the non-farm bundle, standardize the NAS treatment protocol, and then we had connecting with outpatient support, partnering with families, and partnering with other stakeholders as well. On our next slide, key strategies to accomplishing our aim, really again to hit the point home here, standardizing the processes for identification, evaluation, treatment, and discharge management. And I think that the biggies were standardization of Finnegan scoring and standardization of both the farm and non-pharmacological care. I'll talk a little bit in a short while about our compassionate care angle and how we did attempt to standardize that and measure it, which measuring attitudes can be a bit challenging as that is somewhat subjective. Next slide. So we'll start out with the high reliability and NAS scoring. And I think that really this is the foundation of making certain that you're on the right track for NAS treatment. At least it was with our participating sites. All sites use the same tool. The goal was to have 90% reliability in scoring for all RN staff caring for the NAS infant. They were able to see a drop in the max score, the Finnegan scores, once training was completed. And the training system, the Dippolito training system, OPQC purchased the DVD and workbooks for all of the sites, and all the sites went ahead and had their RNs, and some even went into their mother-baby unit as well to have those nurses as well become fluent in the Finnegan scoring. We also posted on our website several of the tools. This is just one of them, the interoperability scoring sheet. We had the definitions. They're all on our website as well. If you'd be interested in looking that up, you can go ahead and go to opqc.net. And then we also have the, if you search under projects, under neonatal abstinence syndrome project, there's lots of different tools there that you're welcome to download and use. Alrighty, so why use the tool? So 2005, 81% of centers utilizing an assessment tool for Finnegan scoring, only 52% of them had guidelines. You do have common language, decreasing variability, and then also improving parent communication and involvement. Some of our teams specifically worked with parents, and if they were there and willing and able, they would provide some education and have the mom and baby score, or mom and nurse score together, which really had some nice outcomes for some of our teams. It is based on opiate withdrawal, one tool for all substance withdrawal. We talk also about the tobacco exposure, polysubstance, benzos, things like that. It is strictly for opiate withdrawal. And then some of the confounding factors that I'm sure anyone on the call who has used the Finnegan scoring knows that it is for term, and then when you get versus preterm, and then also some of those babies that are there for a month or two beyond that neonatal period. Also, staff training and competency maintenance. This is something that was really built into an annual review for many of our teams, where they had to do their neonatal resuscitation, their CPR certification, their bloodborne pathogens, things like that. So that a lot of teams worked on that as well. And then lastly, even though they do attempt to make it as objective as possible, there is still some subjectivity there. Next slide. Alrighty, the Finnegan, originally developed in 1975 and modified in 1986. There are various modifications out there, so OPQC felt it was really important to go ahead and purchase that system so everybody was using the same modification. It was initially tested on 200-term opiate-exposed newborns again in the 70s. It assessed from the beginning of one feeding until the next, so every 3 to 4 hours you were to score, and then obviously if you're breastfeeding, if mom is breastfeeding, that can be challenging, as breastfed babies aren't necessarily on an every 3 to 4 hour feeding schedule. Back in 1975, Dr. Finnegan recommended that you start scoring at 2 hours of age, and if the score is equal to 8, you continued to score every 2 hours until it was less than 7. In 2014, when OPQC first started with the potentially better protocol that was adapted from the Ohio Children's Hospital Association, the recommendation was to treat for 2 consecutive scores greater than 8 or 1 score equal to or greater than 12. Maintaining inter-rater reliability. So this is one of our sites that was in the OCHA project that was a leader and really decided that this is what they were going to fix. They really wanted to work on Finnegan scoring before they started delving into other aspects of treatment. They did it. They started out with a site survey after they'd had initial training. 67% of the RN staff responded, and there was about 15% that felt somewhat or not comfortable at all. And again, that's scoring for older babies, and excoriation were the biggies. 37% wanted more training, and 26%, so a full quarter of them, were not conducting the inter-rater reliability scoring properly. Next slide. So what did they do to fix this? The DVD that comes with the training, assessing signs and symptoms of neonatal abstinence syndrome using the Finnegan scoring tool, is a video that comes with the training. All the RNs watched it. They were able to put it on their EMR. They had unit-based super users that re-educated all staff, and they made certain that each of these super users were on each of the shifts. It wasn't just day shift. It was on weekends. It was on days, nights, 8s, 12s. They wanted to make sure everybody had that opportunity to work with a super user. They had lunch and learns with the 2013 VON INCQ NAS webinars, which I think that you also have access to as a participating VON team. And then the dual score was, they had to score with another nurse at least every 12 hours with a super user or an NNP. And then the reliability scores after, rolling this out within their staff increased to 98%. So they felt pretty comfortable that they had achieved what they were trying to do. This is not a commercial for Neo Advances. I'm not, all I'm doing here is putting out that it is available online, and this is what we used with Ohio Perinatal Quality Collaborative. I know that some of the sites we worked with worked on having their own type of training program implementing some of this, including some of these aspects, but this was the standardized program that we did use that is available for purchase from Dr. DiPolito and Dr. Finnegan online. It's under Neo Advances if you're interested. And the next slide, on our website, this is a great presentation. Dr. Erin Keels is a neonatal nurse practitioner at Nationwide Children's, and she did a great presentation at one of our learning sessions where she had the video where the baby was withdrawing, and they had to grade with the Finnegan scoring next to somebody they were sitting to that they didn't know, and then the whole room went through inter-rater reliability. It was really a fun exercise. I think everybody learned something and was able to talk about what did work together, what the inter-rater reliability points worked well, and what others had some struggles with. So if you're interested, it is on our website, and I think Katie will be sending out these slides as well, and you're able to access the video there if you're interested in that. All right, next slide. Once we identified the infants, we did go with, I guess I should have put the non-pharmacological treatment first, because that is something that you definitely want to initiate prior to going to standardized pharmacological treatment. But we had the protocol that we recommended from the OCHA work, and we did tell teams that it was fine to deviate from that if they were testing, but if this is something that they just wanted to work with and see how it went, that they were really, it would be best for them to adhere to this protocol. There were a few sites, like I mentioned in the OCHA site as well when they started, that were using methadone and morphine, and we did have one site that was using methadone, and then their NICU was purchased by Nationwide Children's, which was a morphine based model with all their sites, and so they went ahead and transferred to morphine, which I thought was a wonderful opportunity to learn from. Here was a team that did very well with methadone and very well with morphine also. So I think that the important thing again is that you are choosing a drug and adhering to it. What we decided in 2014 was to start with 2 consecutive scores that were 8 or greater, or 1 score equal to or greater than 12. And then the morphine or methadone, you needed to select a drug, escalate if greater than 12, stabilize if no increase for 48 hours, it was stable, and then you could wean 10% of max dose daily. And again, this was 2014. I'll share with you in a bit what we did moving forward after additional data collected over a couple of years with additional babies. The next slide, we talk about non-pharmacological treatment bundle. And the slide after that details the elements that we'd said our non-pharmacological bundle would be. Decreased stimulation, and some of these were difficult based on location. If it was a normal newborn nursery, those nurseries are pretty loud. Decreasing stimulation where the lights are on all the time and babies are crying, it can be challenging. Rooming in for mom and baby. If baby is receiving methadone, the baby really should be on a CR monitor, so is it possible to do that and have mom room in? Swaddling, skin to skin, which is wonderful if mom is available and is there. Breastfeeding, we really did promote breastfeeding as safe and effective. When we first started out, and this ties in a little bit to the attitudes that we talk about, I was on a webinar specific to breastfeeding, and one of the neonatologists said, I don't even understand why we're suggesting this. I really think the only reason these moms breastfeed is to look good for children's services. And I thought, gosh, we have a lot of work to do. So I really, the evidence is there that it is safe and effective, promotes bonding, very little MAT medication in breast milk, and some have even suggested that just that little bit is a little help there for the infant, and it can potentially reduce the length of hospital stay, which research has shown, has suggested. And then in 2014, we were suggesting low lactose formula for the baby who is not breastfeeding. In our next slide. This driver was to improve recognition and non-judgmental support for narcotic-addicted women and infants. We utilized this attitude measures survey. It came out of Australia, and it's to focus on people's attitudes towards alcohol or drug use to explore and evaluate attitudes towards them. Pretty much the perceptions about a patient's deservingness of medical care. And on the next slide, you can see the well, here, what did we do to try and improve this? Let me start with that. No, Katie, you're right. Next slide. There you go. So what did we do to our interventions to improve attitude change? We also had the Nurture the Mother, Nurture the Child video, which, again, I believe you get that with being a NAS participant. This comes out of Sheway in Vancouver, British Columbia, and Dr. Ron Abrams does a great job just talking about the environment there and the openness, the non-judgmental approach there. I think probably the most important thing was sharing stories from pregnant women with opioid use disorder. We had a session, a learning session where we invited moms. We had a mom who had adopted an NAS infant. We had a mom who was a peer recovery coach and had been in recovery for over 18 years. And then we had a young lady who had a 4-month-old who was newly sober. And just talking about their journey, their decision to stop using, the shame and guilt that they felt around this. I really think that it was quite impactful to our teams, to our doctors, to our nurses, to really everybody in attendance. And then also that was coupled with education that addiction is a chronic disease, not just a moral failure. And those were lectures from addiction specialists who were also delivering babies that family practice docs that were also addiction specialists. And I think that also was very helpful. And then lastly, community resource outreach. And this is where we had our teams identify a local resource that would be helpful to support the mother-infant dyad and reach out to them and then come back to to our learning session, and this was part of their storyboard that they put together, and then they were in local groupings and talked about the site that they partnered with. My favorite success story is one from the southern part of the state where the addiction rate is pretty bad. The NAS rate is the highest in the state, and the book, Sam Krinis's book Dreamland, is actually based there in Portsmouth, Ohio. And the director of nursing, maternal child nursing at the hospital, reached out to the local addiction shelter and asked about resources, and ended up, the woman there asked if perhaps she would come talk to the women that they had at the shelter that were pregnant about what to expect when their baby was born. So she and another nurse went there and gave a brief overview, explained characteristics of NAS, explained what kind of treatment to expect and such. And one of the moms asked if she would be able to have a tour. And the nursing director said, oh, of course, there's the third Wednesday of every month. You're more than welcome to join. You can sign up online, or if you don't have access to a computer, you can call. We'd love to have you. And this mom said, I wouldn't feel comfortable with the regular normal moms, which is pretty heartbreaking. She said, I don't think I could go there and do that with everybody else that is just normal. And so the nursing director, to her credit, suggested having a tour just for this patient population there. They had them come one evening, and the nurses were there. They had a bit of a welcoming party for them. They talked about NAS. They showed them what the monitor would look like. They showed them where the baby would be. And went through that. It was so successful. It's something they do now on a monthly basis. The nursing director said it was a win-win not only for the patients but for her nursing staff as well. Often the moms would come in and say, oh, you did my tour and you just made me feel so much better. And it really kind of humanized them. And like I said, it was my favorite success story of just the community resources outreach that our teams did. On the next slide, these were the questions that we asked. We asked these questions over the 3-year period. There were 3 time periods that we reached out to the teams to fill this out. And we did have significant difference with 5 of the 7 questions. I think the other 2 scored high enough to begin with that there wasn't really much of a change. But the questions are, do you feel angry towards people using drugs? To what extent is an individual responsible for their drug use? Do you feel disappointed? To what extent, and this is one that was pretty high to begin with, to what extent are adverse life circumstances likely to be responsible for the drug use? To what extent do you feel sympathy? To what extent do people who use drugs deserve the same level of medical care? And that one surprised me, that we did have lower scores to begin with, that there was statistical significance. And then lastly, to what extent do you feel concerned towards people using drugs? All right, so next slide. So after 9 months of work, the length of treatment decreased 9% from 13.4 to 12 days. And then the length of stay, again, remember that's our AIM statement and funded by Medicaid, so, truly return on investment as well. Length of stay decreased by 9% as well, from 18.3 to 17 days in 2014. Next slide. We did write up the phase 1 publication published in Pediatrics, and again talking about the importance of standardizing treatment and adherence to a protocol. And then the next slide, there we go, yeah, standardized approaches, non-farm identification. So in 2014 we were thinking, well, have we done all we wanted to do? And there was discussion amongst variation in our non-farm care bundle, and specifically in feeding. So it was the low lactose feeds and the 22-calorie feeds. So we wanted to see if there was something there that we could really think maybe we could push the envelope even a bit further. So next slide. We came up with what we called orchestrated testing, and it was based on kind of like a factorial design, planned testing across multiple sites, and we wanted to, again, standardize and be systematic about testing simultaneously different change ideas. So we wanted to standardize practice, reliable implementation for faster and more efficient learning, and we had 4 different groups that we used. So the next slide talks about those 4 groups that you could select. We went with 2 change ideas, which were the factors, type of formula and calorie content, and then 2 levels of each, standard lactose versus low lactose, standard calorie versus high calorie. Each of the 54 sites went ahead and selected. OPQC did not say you're in this group, you're in this group. We asked each of the sites to select for themselves, and this went from October 2015 to June 2016. Next slide. Group 1 had 22-calorie low lactose. Group 2, low lactose 22. Group 3, low lactose and regular calorie. And then group 4 was it was standard formula, not low lactose, not high calorie. And again, they all self-selected. I can tell you of the most of the groups were in group 2 or 3. So we were measuring length of stay, treatment failure, and we identified treatment failure as the % of infants that required a dose escalation, they failed a wean, or they needed a secondary medication. And then also the weight loss of greater than 10% was also a measure. Our results that, showed that use of 22-calorie could be beneficial practice for NAS non-farm support. It showed a consistent benefit on weight loss, treatment failure, and length of stay. The benefit of low lactose was not consistent across all those outcome measures. There was a possible synergistic effect with the 22-calorie on the weight loss and length of stay, but not on the treatment failure. So we told teams we would recommend you start using 22-calorie formula, the low lactose portion of it, if that's something you want to do. You know, it's not harmful. We just don't have the evidence that it's as beneficial as the 22-calorie. The next slide. We then, based on our data, went ahead and made our new recommendations. Remember, the first ones came from that OCHA, Ohio Children's Hospital Association project, and so we upgraded and changed it in 2016. All infants treated decreased stim, swaddling, continuous holding, and frequent feedings was the recommendation. Breastfeeding if mom is in treatment. And we did see breastfeeding go up, and then towards the end of the project, it did fall down. If breast milk was not used, we did recommend 22-calorie formula and low lactose at the discretion of the unit. And then the next slide, for the standardized treatment protocol, the pharmacological treatment, there were changes to the methadone protocol, and that was on a pharmacokinetic-driven protocol. It showed shorter length of treatment, hospitalization, and so we changed initiation of treatment also to greater than 8 3 times, not 2, and then greater than 12 2 times, not 1. And then also the morphine escalation doses were score dependent. We did see one of our sites, well, not just one site and its affiliates really, they were testing the morphine escalation specific doses, and that really found to be a shorter length of stay and length of treatment for those infants. And so based on that data, the recommendation was to make those escalation doses score dependent. Our treatment protocol is also available on our website at opqc.net. And our next slide, you can see here the pharmacological bundle, Finnegan scores, greater than 8 3 times, greater than 12 escalate. If they remain elevated, increase. Maintenance is 24 hours on methadone. That was based out of that study in Cincinnati. And then maintenance dose for morphine is 48 hours. And then again, there's a step daily for methadone that is on our website, and then it's a wean by 10% for stabilizing dose off of morphine, and then both are discharged 48 hours off methadone or morphine. Phase 2 improvement, this is after our orchestrated testing and changing those methadone approach there. We saw increases in both the use of 22-calorie and low lactose feeding, even with the recommendation for the 22-calorie. So you can see that on the left with 22-cal and the low lactose, not as big as a jump, but at 74% there. And next please. So you can see here, again, after the initial year there, we had further reductions in length of stay, reduction in length of stay from 18.3 to 17, and then from 17 to 16.3 with that orchestrated testing, with a total reduction of 2 days. And then lastly, I want to include here, talking about standardization, is partnering with families to establish plan of safe care for the infant. This was one of our last drivers, and the intervention was to collaborate with DFS and Children Protective Services to ensure infant safety. And initially, this is something that I don't think we accomplished as much as we would have liked to in Ohio. We did have different counties have different reporting recommendations or rules, and that isn't necessarily something that OPQC had control over. So moving forward, we are now working on a project that's called Moms Plus, and that plus is the baby, so that having the maternal opiate medication support, and then the infant as well, really trying to maintain that maternal infant dyad. We are working with Job and Family Services and Child Protection Services to standardize this throughout the state. And they have put together a guide, a mandated reporter guide, Plan of Safe Care, and they do want all babies, regardless of mom being in a treatment protocol or treatment program or not, to be reported. And I think that was probably the biggest variability, the biggest discrepancy from county to county. And you know, our counties, I'm sure just like in Georgia, you serve several counties within one hospital. So it really was quite a burden for the social worker trying to figure out, if this mom lives in this county, this is what I need to report. But if mom lives in this county, it's a separate report. So this is something the state is working on. We're not quite there yet, but we are making, I think, good headway. I think also a big push that is happening with Child Protection Services is that they're trying to, our teams are trying to work with the moms while they're pregnant to have all this in place. So there aren't surprises in the NICU that the baby can't go home with mom. A lot of the sites that have maternal opiate support or have a mom's project ongoing, they will bring someone from child protection team in the county to the hospital to talk about what it is that a plan of safe care includes. And do you have, are you compliant with your treatment? Do you have support systems? Do you have everything you need for the baby? Do you have a safe place to live? So I think that we are making headway and we are attempting to standardize this. And I think the other thing that is really nice is that some of the, that's progress here, is some of the teams are actually working on filling out as much of this as they can with the patient prior to her going to the hospital. So this is part of her record, and this is something that when she goes in, she can say, here is my treatment plan, here is the list of my physicians, here is the list of my support system. So I think that having all this and bringing it to the hospital, we have found has been helpful, and I think that it's been, again, kind of similar to what was happening in Southern Ohio with the prenatal visits. I think it's a win-win both for Children's Services and for the parent who is active and staying sober and being compliant, to have all this in place for her baby prior to delivery. And next slide. And Katie, that's all I have. Hopeful that was a good overview about the standardization with our program and our protocols. And I'm happy to take any questions.
Thank you, Susan. That was wonderful. It was a really great overview of the work that y'all did in Ohio. And, you know, we're just starting out with our baseline audit this week, actually. And so I hope that for all the participating hospitals on the call, I hope that was just a really helpful overview of the change that can happen through this collaborative. So I'm not seeing any questions in the chat box, so I'll just give it a minute and see if any come in. And then if not, I have just a couple updates for everyone.
Katie, I'm wondering if you could answer a question for me. Is there a key driver diagram for your NAS project for the state?
There is, yeah, and I would be happy to share it with you. Yeah, we've shared it on previous calls with our teams, and then we had an in-person initial kickoff call, meeting, just a couple months ago, and shared it there.
I think that's always helpful, and I think too that as evidenced by the OCHA project and then just the variability across the state, I think that we had a lot of teams starting at different places. And, you know, a question I'm often asked is, what do you think is the most important thing when you're starting out? And I think that trying to figure out what it is each site wants to accomplish. So you have a key driver diagram for the overarching work of the state and the collaborative, but then also I suggested to all of our teams to have, you know, team aim statements in addition to that. You know, perhaps your team is really great at Finnegan scoring and you've really done well with inter-rater reliability, or you've got a protocol that is working well at your hospital for farm treatment. And then from there, those were those individuals that I always wanted to highlight on a call or a webinar to, to teach others with that All Teach, All Learn.
Yeah, that's great. That'll actually be one of my reminders when we end is all of our teams right now are working on putting together their aim statements. I have it from some of you are waiting on your data back from your Vendée audit, which is perfectly fine. We have a few questions, so I'll read them out. Great presentation. Could you let us know what the trends are with morphine versus methadone use in light of recent studies suggesting greater efficacy with methadone?
That's a great question, and I will. I'm going to put you in touch with Dr. Scott Wexelblatt, who is one of our NAS faculty members at OPQC. He's the one that led that study in the Cincinnati area with methadone, and I do know that there was a shorter length of stay and shorter length of treatment as well with methadone, and I think that he'd probably be best to speak to the ins and outs of that.
Okay. And we have another, that was a wonderful overview, and just wanting to point out that it makes sense to give higher calories. So that's a comment there. Okay, what is your second line of drugs you use if methadone or morphine is not working?
That would be clonidine or phenobarbital. And there was some concern with clonidine where some sites preferred not to use it. I want to say it was like a prolonged QT. I don't believe anybody had that specific problem with it for the sites that did use clonidine, but I would say more of our sites used phenobarb than clonidine.
Okay. And then we have two questions about different resources through Vaughn and if we get access to those from Juliana and Angela. I'm going to check on both of those and get back to you because I think I know the answer, but let me just double check with Vaughn before I give a final answer, and I'll send that out along with the slides.
I see one of the questions, Katie, is about the an NAS family booklet, and while it's not the New Hanover one that Vaughn has, there is one on our website that you are welcome to download and actually customize for yourself. It's, again, at opqc.net, and it's under, I believe it's under Patients and Providers, and it's, we actually adapted ours from Dartmouth Hitchcock's and give attestation to them. But I think there are a lot of good handouts, a lot of good booklets out there. But for those that might be interested in, stealing shamelessly from us, please do so. It's on our website for your use.
Thank you. So I will, while we're waiting to see if any more questions come in, I'll go ahead and just give a few GaPQC reminders. So I just wanted to give a reminder that your Vendée audit period started yesterday. So your data champions should have had an email from Vaughn. I've been copied on these, so I've seen them go out. And we've actually had 11% of our hospitals already submit data. So yay for you all. They said that that's pretty high for a Tuesday in the Vendée audit period. But we'll be following up with you throughout the week. If you have any questions, and just remember you can email me or Bethany for assistance. And again, just a reminder to email Bethany and not Courtney, who presented 2 months ago. She has since left Vaughn, and so Bethany's team is taking over the Vendée audit, and she's very prompt and will provide you with any help. Also, for the learning management system access, most hospitals have received access at this point. They were having a slight delay with it just due to some system issues that came up. At this point, most of them have it. I have a list of everyone who who has access already, so I can see those who haven't. And I've sent them that information again this morning. So I'm hoping that that will start really soon if you don't have it already. But know that that's coming. And then also for your smart names, like I said, I've gotten these from many of you, which is wonderful. Those of you who are wanting to wait for your Vendée audits, that is, again, that's perfectly fine. We would just ask you to try to submit them to us by the next webinar, which is on August 13th from 2 to 3. And this one will be on NAS and the effects of in utero exposure. And I've seen a few more questions come in, so let me just read these real quick. So when using 22 ounce formula, what volumes are you seeing for intake?
That's a good question. I don't know that I have the answer to that just because the project has been over for quite some time. So that, unfortunately, I don't think I can answer. The question about weight gain becoming excessive. So that was usually pretty short term that babies were on the 22 calorie, and it was recommended that you stop it once they went off farm treatment. And then in that manner, you also had, in Ohio, you have to, I would think this might be nationally, that you had to have a physician order to have, for WIC, to have a special formula. So the concern was, how are we going to get these moms on home 122 calorie? But that was never the intent to do that. So there was a 48-hour period after the baby stopped pharmacological treatment that you also took the baby back to regular formula. You could continue low lactose if you wanted, but it was recommended that you went back to the normal calorie intake at the discontinuation of pharmacological treatment. So I don't believe there was any weight gain, excess weight gain, at least not on a regular basis. I want to say it was few and far between. For the most part, we tracked many more babies that had the greater than 10% weight loss, which initiated the rationale for the 22 calorie.
And then what is the Ohio Collaborative looking to do in the future as it relates to NAS infants?
Great question, yes. So we're working upstream. When we had decreased our length of stay, and really we're about where we thought we could be as a collaborative, we decided that we wanted to start working with the obstetricians on this challenge and work with the moms while they were pregnant. So from the NAS standpoint, we are working with 29 hospitals or outpatient OB clinics in the state right now, and a big portion of that is attempting to maintain that maternal infant dyad. And so I think that moving forward in the future, we're going to be working even more so on that maternal infant dyad with hopefully standardized processes and models of care that will really support that.
Great. Okay, I'm not seeing any more questions or comments in the box, so we can go ahead and wrap up. There's just 3 minutes left. But Susan, this was a really, really helpful and wonderful overview to give